night, wherever you are in the world. Thank you so much for joining. I know there are a lot of these seminars, so we're so happy that you have decided to spend your hour with us. My name is Gavin Yamey. I'm a professor of global health and public policy at Duke University, and I direct the Center for Policy Impact in Global Health, a policy laboratory that works on big picture strategic questions in global health financing, governance, and architecture, including pandemic preparedness. This is the third in a series of seminars on global COVID-19 vaccination. And I would like to just spend a few minutes setting the scene for today's remarkable panel. We obviously have now a safe, highly efficacious vaccine, a set of vaccines. The development was unbelievably fast, lab to jab, in under a year. And it's the tool that is our way out of this pandemic if we can achieve global vaccine herd immunity, not just vaccine herd immunity in the United States that we are, racing fast to reach, but worldwide. And we have seen a really appalling nationalism, a vaccine grab that has led to a global vaccine apartheid, with the rich world essentially clearing the shelves of doses. That is, I would argue, immoral, unethical, and unjust. It is unjust that health workers and high-risk people, for example, remain unprotected, whilst low-risk people in rich countries are getting vaccinated. We have to redress that inequity. It is also terrible global public health. Strategically, to end this pandemic, we need to vaccinate the world. We've already seen one of the risks of having uncontrolled SARS-CoV transmission is the risk of new variants, particularly variants of concern. It's also terrible economics. One study has shown that in the most greedy scenario, in which the rich world is basically vaccinated, widespread vaccination by the summer, and less wealthy countries are left behind, the economic loss would be $9 trillion. Half of the losses would fall on the rich world. Exports would be down, supply chains would be disrupted. So whichever way you look at it, we have to redress this inequity. Today, we're going to focus on what it's going to cost to achieve global vaccine herd immunity, where the money is going to come from, and the role of pricing and IP and patents in all of this. One thing I just want to say, the last thing I will say before passing to our first speaker, is you may hear some numbers today that you will think, oh, those seem quite large. You may even kind of get sticker shock, the cost of vaccinating everybody. But it is worth keeping in mind some of these other numbers. And that is, the global economy as a result of COVID-19 has shrunk. The IMF estimates by 4.4% in 2020, the worst economic decline since the Depression of the 30s. The final bill, the IMF estimates to be $28 trillion in economic loss. So when you hear any of these numbers for the cost of vaccination, keep these giant trillions in mind. And the last thing I'll say is, the Rand Corporation found that if you invest $25 billion in redressing COVID-19 vaccination inequity, there would be a return of $119 billion in rich countries alone. That even ignores the benefit to low and middle income countries. So keep those other numbers in mind. So without further ado, let's go straight to our first panelist, one of my colleagues from our center, Mohammed Mustafa. And I want Mohammed to set the scene. Tell us, what is the price tag for reaching vaccine herd immunity in low and middle income countries? Mohammed, over to you.
Mm-hmm. Thank you, Gavin. I'm going to show you some of the numbers, but would you allow me to share my screen? I have a few slides I'd like to present. But
it says that the host has, that the screen sharing is disabled. Luke,
now
Lee, there we go. Great.
All right. Okay. So, so what is the cost of, what is the price tag of COVID-19 immunization in low and middle income countries? So before we delve into that, let's just quickly highlight what is included in that price tag. So Am I sharing the small screen or the big screen?
Looks good.
Okay.
We see it large.
Okay. So when we're talking about the price tag, we're basically talking about two components: the procurement of COVID-19 vaccines and also the delivery of those vaccines. So for our analysis for the vaccine procurement, we looked at the public available prices per dose from 15 middle-income countries. And we assumed the dosing schedule of 2 doses. And then we also looked at the COVAX advanced market commitment to eligible countries. For those, we assumed that $3 per dose for up to 20% of the population. Now, when it comes to the delivery of COVID-19 vaccines, there are some unique challenges because the vaccination is for non-traditional target population. We're targeting adults for COVID-19 vaccines. And also because it's novel vaccines and the agency and the size of the vaccination that we are to deliver. So there are additional costs to the vaccine delivering. And I'm comparing to the childhood immunization, which is the predominant in many of the countries we're talking about today. Many of them don't have adult vaccination programs. So there are additional costs for labor, for supply chain, including cold chain at the regional and at the national level, and also for PPEs and for infection control. And also there are additional costs for pharmacovigilance activities and all. So for our estimates, we used the publicly available data on immunization costs from childhood immunization, and we accounted for additional costs of PPEs and for infection controls. And we made the simplifying assumption that the scale of scenarios will be for healthcare workers, and then for highest populations, and then to population to reach herd immunity, and we use 70% for that. So using these assumptions for low-income countries, the cost per person receiving 1 dose range from $3.6 to $9. For lower middle-income countries, 4 to 16, and up to 29 in upper middle-income countries. So the total price tag to vaccinate 70% of population in LMICs is $74 billion. And in this figure, you can see the disaggregation by different income levels. And you can also see that consistently 60 to 70% of that cost is for procurement, and then 30 to 40% is for vaccine delivery. And obviously, these are benchmark numbers. So in this figure here, we show the main cost drivers, namely the procurement cost per dose and also the country level delivery cost. So in the procurement cost for the countries, we use the median price per dose for about 50% of them were towards the lower end of the spectrum. So as you can see, the range is, the quantile range is $5 to $13. And as countries purchase doses through bilateral deals for higher prices, the total price tag will go up by orders of magnitude. And the price tag was less sensitive to delivery cost per dose. And also it's worth noting that for all the scenarios, we included the COVAX AMC pricing at $3 for up to 20% for the eligible countries. Here we show the disaggregation by different scale of scenarios. The cost to vaccinate healthcare workers is $0.5 billion, and also for high-risk population, it's $4 billion. And you can also see the disaggregation by different WHO regions. So what does this all mean? If you look at, instead of 70%, vaccinating only 20% of the population of these countries, and compare that to the annual historical expenditure immunization. Analyzed 172 countries we looked at, around 6 in 10 countries will spend at least double their annual immunization expenditure, and 2 in 10 countries will spend at least 5 times for the annual immunization expenditure, and that's for 20%, not for the 70%. So you can imagine the order of magnitude for if we to vaccinate up to 70% of the population. For the figure on the right, these are all low-income countries, and this is just to show you the country-level data. And the values for each country are available through an online dashboard. We will paste the link in the comment section in the chat box. But here you can also show the values and the different scale-up scenarios, and also you can opt to include COVAX pricing. And you can show country-level data, an example from Sudan here. And thank you so much.
Thanks so much, Mohammed, for setting the scene. This new app, Mohammed led on its development, showing pricing and costs. It's remarkable work. 74 billion, keep in mind what I said before, $28 trillion of economic loss. So this has to be kept in perspective. Just a note that the audience, you can start posting questions in the Q&A function, and the panelists will answer some of those live. We'll also have around 15-20 minutes at the end for a discussion. Our next speaker is our colleague, Duke Can Zhang from the Duke Fuqua School of Business, an assistant professor. Can, we would love to hear from you. Give us a China situation. What would be the costs for vaccination in China, and where is the funding going to come from? We should probably also note from Mohammed's slide, the low-income countries and the lower middle-income countries, we're going to hear, I think, from Hannah Kettler, their doses will be funded, or largely funded at least, through the COVAX advanced market commitment, but not the upper middle-income countries. They will need to pay themselves. Can, over to you.
Thank you, Gavin, for the great introduction. It's a great pleasure to have this opportunity to present here. So my name is Ken. I've been working with Dr. Tang and a few excellent alumni from Duke Global Health Institute on COVID-19 vaccine delivery in China. Mustafa already set up a really good scene in general, so I'll present some preliminary results and also high-level ideas related to the costs and financing of COVID-19 vaccines in China. So I'll start with an overview of the COVID-19 vaccination financing policies in China. So before the end of 2020, so there was no specific national level policy for the financing of COVID-19 vaccines at that time. Individual payments consist of an important part. For example, some provinces had started providing vaccines to students who study abroad, and with a price of about $60 per person for 2 shots. Then on December 31st, 2020, it was formally announced that COVID-19 vaccination will be free of charge for all people in China. And on January the 9th, a few days later than December 31st, it was further specified that the costs of COVID-19 vaccination will be paid jointly by the health insurance funds and different levels of governments in China. So given this background, the main 2 points I'd like to discuss today are, first of all, what are the estimated costs for COVID-19 vaccination in China? Secondly, what are the implications on health insurance and the government spending? So first, regarding the costs, we consider the range of coverage levels from 50% to 80% of the population to achieve herd immunity. We also considered 2 price levels. So first of all, the $60 scenario here is really an upper bound. It comes from the price that was previously charged to individuals. And we expect the government bulk purchase price to be lower than this individual price. So we also considered the scenario with 100 RMB, which is about $15 per person, kind of fall within Mustafa's range. So under this price scenario, still at least $10 to $20 billion are needed to achieve herd immunity. So in addition to procurement, there will also be distribution and administration costs. Some good news is that the 2 approved vaccines in China are inactivated vaccines. So the storage and cold chain requirements could be relatively low compared to the mRNA vaccines. So however, given the large territory and population in China, the distribution could still be quite expensive. So there will be some additional cost burden here. Since the current plan is that these costs will be paid jointly by the health insurance funds and different levels of governments, we further looked into some numbers in both the health insurance scheme and the government fiscal space. So first, we observed that there is a large disparity in the balance of the resident resident basic health insurance here, where the balance in west part of China can be much lower than other parts of China. And moreover, the national balance of the resident basic health insurance is about $79 billion in 2019. So based on the cost numbers we just estimated, it is clear that purchasing COVID-19 vaccines could be a heavy burden for the health insurance, especially in less developed areas such as the west part of China. This could also have significant implications on the access to other general health care. Finally, we also looked into the fiscal space of governments at the province level. A key observation here is that for central and west part of China, their own revenue, which is the blue bar in the figures here, could actually be much lower than the east part of China. Moreover, many central and western provinces need a large fiscal transfer from the central government to balance their books, which is the orange bar represented here in the figure. So overall, the fiscal space for governments at the province level could also be quite tight, and this is especially the case for central and western part of China. So to summarize the presentation today, purchasing COVID-19 vaccines and their distribution could be a heavy burden for both the health insurance and local governments, and more research as well as practical plan on how financial resources can be allocated to support the vaccination, especially in less developed regions of China, is needed. And that concludes my presentation today. Thank you.
Thank you so much, Kan. And I'm really looking forward to hearing from Ben Akabaweze on the Nigerian situation and seeing if there are lessons to be learned across countries, and also from Srinath Reddy on the Indian situation. Susan Sparks will shortly be discussing budgeting and how you think about vaccination within national budgeting. But next up is Hannah Kettler from PATH. Hannah is the Director for Vaccine Financing and Purchasing at PATH, and she is currently on secondment to COVAX. And she's going to address a very, very easy question. How should the world pay for COVID-19 vaccines, and where does COVAX fit in? Give us a, bird's eye view, sort of from a global perspective. How do we begin to think about this thorny question?
Thank you. Thanks. And hello, everyone. It's a pleasure to be here. So as Gavin emphasized in his opening remarks, the development of the vaccines has proceeded at unprecedented pace. But we also know that in order to realize and eliminate this ultimately this virus, but control in the immediate term this acute phase of the pandemic, we need to focus not only on having vaccines, but making sure that they're globally available and distributed. And a critical question, as speed is so essential, we've done an amazing job as a globe and with significant investment, both public and private, in the accelerating the development of vaccines. The question is, what do we need to do to ensure we've got sufficient scale and manufacturing capacity? Because again, we're talking billions of doses and we're talking global launches. And so one key question is, how do we have sufficient manufacturing capacity? And then the second is, what are the models that we really need to ensure that there isn't this gap between the high income countries receiving doses and the rest of the world? And we know from past experiences, as recently as H1N1 in 2009, that even when we have vaccine supply available, we have, if we allow the markets to really determine how vaccines are distributed, if we rely only on that, we end up with significant time gaps between the introduction of vaccine in high income and low income. And so at the same time that there were researchers, companies, scientists investing as quickly as they could in new vaccine development, there was simultaneously a global effort focused on how do we ensure we don't have that gap? What can we do? And Gavin also referred to, and everyone's very well aware of these discussions about countries, scouring the globe for vaccine, over competing for contracts, overbidding with each other to secure. And the question is, how do you create purchasing power for developing countries, low income, but also upper middle income, that on their own are not in a position necessarily to compete with enough resource. And the organization COVAX, which has been referenced a couple of times, was the product of some of this early thinking around what kind of approach can we take to ensure this gap is narrowed. And COVAX is established as a partnership between many organizations, most notably the World Health Organization, Gavi, the Global Alliance for Vaccines and Immunization, as well as CEPI, the Coalition for Epidemic and Pandemic Innovations. And these groups came together with a model that had a number of components, but a key piece of it was, how do we create purchasing power? So what is the model that we will be able to use to raise sufficient funds and go and create an incentive to the manufacturers to put some attention towards the purchasers in the rest of the world? And the concept that was developed, often in the global health world, there's a heavy reliance on markets to buy in high and maybe middle income countries, and then donor funding as a tool and a source of funding for the low income countries. And what is unique to the idea of COVAX is one of, we really need, pooling's not unique, but the idea of bringing into a global mechanism, self-financing, as they're referred to, high income, low income, middle income countries, and low income, so donor funding. How do you bring country funding and donor funding together effectively so that you can compete with others? And so COVAX was established initially in the summer and has successfully, I would say, brought in most of the world as participants. So there's over 190 countries that are members, are participants. But the trick was, how do you get sufficient funds in that pool? And the pitch to the high income countries, many of whom were already well positioned, and in fact were very actively involved in trying to bid bilaterally for doses, was one, the idea that COVAX could, compete and try to invest in a portfolio so that there'd be some risk mitigated for not picking one or two winners that ended up being losers. So how did, COVAX was positioned to invest in a portfolio, but also that you could be part of this global solution that ultimately had true economic benefit for you as well as the rest of the world. To date, the organization has been able to raise on the donor side $6 billion, 6.3, I think, and then has brought in a couple billion similarly from the self-financing side. And as a pool, is actively involved in negotiations with countries and companies, with the goal to try to access 2 billion doses with a focus on vaccinating up to 1 billion in 2021 alone. And again, essential because of the importance that getting vaccines into every country with a target of 20%, but starting with healthcare workers and essential workers, how do we make sure vaccines get to everyone who needs them? So I think long-term, COVAX is not yet sufficient to meet the demands in all of these countries, clearly. 2 billion doses is not enough. There's a target to raise additional funding, but there's both an issue of how do we get enough supply into this pool, is that successful, but also long-term thinking through what are some of the complementary tools that make sure that you're not relying exclusively on this one pool, but also creating a space where the manufacturing costs come down, whether supply goes up. Those are different tools through which the price is also impacted, not purely by the negotiation power of COVAX, but some of these other investment tools. So I think it's a really essential, critical piece. Doses went into country in February in Cote d'Ivoire and Ghana. While not simultaneous launches, it was within a couple months of doses being administered in the United States and in the UK and Israel. And so that's something to celebrate, that we actually narrowed sufficiently that introduction gap, but we have a lot to go, a lot of work to do. And so look forward to any further discussion on that. Thanks.
Fantastic. Thank you, Anna. I was part of a working group that helped to advise on the design of COVAX. So I feel also a bit defensive about it as well. And I think it's clearly, it was at the back of the queue to get doses because rich countries were buying up all the doses, but it seems to be taken off now. One of the audience asked about the Trump administration and its stance towards COVAX and how things have changed. Things have changed dramatically. The Biden administration has joined, officially, and has donated so far $2 billion with the promise of another $2 billion if that's matched by other rich countries to the COVAX advanced market commitment. That's the pool of funding that's buying doses. So I think there has been a change with that administration. So in the interest of time, let's move on to Susan Sparks, who is a health financing technical officer at the WHO, who I think is going to talk to us about the budgeting and financing when it comes to national vaccine rollout and how we think about that from a health systems perspective. Susan, over to you.
Thanks, Gavin. Yeah, the really exciting stuff, the budgeting and financing. And I'm going to try to, I want to echo all the positivity that's been said so far, but I do have to admit that I will be bringing a little bit of a dose of some hard medicine, I think, as well as we look into 2021, 2022, in terms of the fiscal outlook. And so first, in terms of setting the scene, so I want to make clear that I'm talking about the financing and budgeting. And this is different than and distinct than purely a funding and revenue question. This is about getting the money into the system and then actually translating that money into services, into jabs, into arms, into health workers who can deliver those services. And so first, what we know is, as Gavin started off with, is that COVID-19 is not just a health crisis, it's an economic crisis. And it has led to hundreds of millions of people put into poverty and economic contraction. And so even as we start to hear signs of recovery, it's important to remember that we're now starting at a much lower level. And so growth is from a lower starting level in terms of that economic contraction and the impact. And so as we face this COVID vaccination rollout, we have on the one hand, a upward pressure on health spending, right? So we have an upward pressure from the vaccination, but we also have an upward pressure just from foregone care, delayed services, all the essential health services and the pulse survey data that WHO and others have come out with, that we know that there's this backlog of issues that are yet to be dealt with. And so we have these really two competing forces in the midst of economic contraction. I think importantly, countries have taken on debt to pay and for this initial phase of the economic stimulus and the response. And they entered, on average, countries entered 2020 or 2019 even at a much higher debt level than we've seen in recent crises. And so the economics were already challenging for countries. And we have this increasing poverty. So you have less money in people's pockets. Okay, so that's some of the framing of the challenges from the financing side. But I think importantly, there's some really practical steps, and I speak to this crowd, but it's also as an economist working in WHO, we're also speaking to the public health crowd more broadly, in that oftentimes there is a focus on let's get the plans in place, let's get the costs in place, let's get those numbers. But the question is, and some of the challenges is that can often lead to these very high price tags. And so this question of how do you have more of a back and forth between the fiscal realities, whether it's at the global level in terms of donor assistance or COVAX financing, as well as the domestic financing and funding realities. And I think that this is really important to have this back and forth, because what we know is efficiency is going to be really critical. And just before this call, there was an article in the New York Times that I'm sure Srinath has more insight on, about the rollout of the COVID vaccination in India. and this question of what systems is this vaccination process taking advantage of? What are the functions in the countries that are already in place, whether it's polio vaccination programs or other immunization or primary health care or MNCH services in Sri Lanka, for instance. And so really coming into this rollout with this lens of what are the resources that are there that can be leveraged, that can be built? Who are the budget holders that need to be involved? And that's not just at the national level. The money needs to be able to flow all the way to the front lines. And so it needs to get down to that level of the subnational. And so thinking through who are those budget holders, where can the money come from, but how does it actually get there? And that's where this PFM, the public financial management systems, are so critical. And so moving beyond price tags into actual system analysis, understanding, okay, are there potential World Bank loans that are coming in? Are there other sources of funding? What is the debt outlook within the country? I think what we need to recognize in 2021 is that this idea of balanced budgets is completely out the window, as well as austerity. I mean, that's not the situation that we're in right now, but there are still real constraints that are in play. I was just in calls, I mean, even related to COVAX, I think it's an amazing thing to get these vaccines out, but who's paying for the fuel to get those vaccines to the facilities? Where are the health workers? I mean, I'm thinking from a low and middle income setting, and even in Ghana, I was in touch with our country office there saying, okay, so what's the financing plan? And they sent me an enormous gap analysis, a gap analysis in terms of funds, a gap analysis in terms of population, in terms of resources. And so I think we really need to start thinking much more operationally. So we're beyond the phase of initial fundraising and kind of even costing into what are the operational realities. These vaccines are rolling out. Where is the money going to come from to get those vaccines into the arms of people using the available resources and not just new funding resources? Because I do think in global health, I just want to end with just kind of a message that we've learned the lessons of oftentimes we can put blinders on and the verticality and this run towards the goalpost without thinking through the broader system issues. And so my hope is with the COVID vaccine rollout, that maybe we can learn some of those lessons and really invest in what we call the common goods for health. And so these cross-cutting platforms, how do we make sure that the surveillance systems and the labs and the supply chains and the water and sanitation in this moment of global attention, national attention on the importance of public health and preparedness, how can some of these resources really be channeled towards system building, towards building these common, really important platforms as we kind of go into maybe this, we have this initial phase, but we know this rollout is going to take time. And so how do we prepare for that in an operational sense with this efficiency, this system building lens? And yeah, I'm hopeful that it's going to move in that direction. So thank you.
Thanks so much, Susan. Just a couple of quick responses. Firstly, yesterday, our center co-hosted an event with the OECD about the future of financing in the COVID-19 era. And there was a remarkable amount of optimism that this could be seen as a health system resilience moment, that of course the response is going to be a big lift, but there's a chance to use this moment to build systems for the future. And perhaps Ben and Srinath may touch on that. And secondly, I just want to say that your director, well, the WHO's director of the health workforce, Jim Campbell, when he saw this event was happening, took to Twitter to say, people, health workers, who's going to deliver these? Who's actually going to deliver these vaccines? I hope you're going to touch on that. So I'm pleased that you raised that. And that's actually a very nice segue to our next speaker, Ben Akabueze, who is the Director General of the Budget Office of the Federal Government of Nigeria. We would love to hear from you, Ben, about Nigeria's plans for vaccine financing. Ben, over to you. Ben, are you there? Are you with us? I see that you are, but I'm not sure that you hear us and know that you're on. What I'm going to do, I think, is, Srinath, I'm going to pass to you, and then I'm going to ask my Duke colleagues to ping Ben and see if we can connect with him. So next up, Srinath Reddy, the director of the Public Health Foundation of India, who I have personally known and had the privilege of working with since 2012, the Lancet Commission on Investing in Health. Srinath, how is India approaching the finance and delivery of COVID-19 vaccines, particularly with your very ambitious UHC expansion? How does that fit in? Over to you, Srinath.
Thank you, Gavin. Well, given the fact that India has a very strong manufacturing capacity, which is further expanding now, even with international financial support and investment coming forward, because the world now recognizes India as a valuable asset for manufacturing vaccines for global use. I think India has positioned itself in terms of its vaccine production, pricing, and delivery within the broader but not fully well-defined framework of universal health coverage. Firstly, India decided that vaccines would have to be provided free of cost in all government facilities and at very low cost in private sector facilities, which at a later stage were permitted also to administer the vaccines, but with the government controlling the supply of the vaccines and ensuring that there are strict price controls for the actual vaccination in a private care facility for those who choose that facility. People have that choice whether they would like to get the vaccination totally free of cost in a government facility, or for a variety of reasons may opt for a private facility, but at a relatively low cost, which is price controlled. Obviously, in terms of actual production dynamics, there are two vaccines which are currently provided through the system after having obtained regulatory approval. One is a vaccine that has been contracted by AstraZeneca for production in India by the Serum Institute of India. And the second is a vaccine that has been developed within India by the National Institute of Virology and produced at Bharat Biotech. Now, both these are price controlled at the moment because it's the government that actually procures the vaccine at a low set price and supplies free of cost in government facilities. But even in the private facility, the charge is at the moment pretty low. It is about $3.50, out of which $1.50 is the service charge levied by the private hospital, and $2 is the government price, which goes back into the government treasury for further vaccine supplies. So this is, of course, optional for an individual, whether he or she would like to go to a private facility or go entirely to a public facility. And of course, the delivery is being marshaled through a number of pre-existing mechanisms, which include the Universal Immunization Program for children and women, which has existed for quite some time, but that's been expanded now, not only for additional government facilities, but initially for private hospitals of a certain size and accreditation. But now the policy is also to make it available in smaller nursing homes, of course, with the government still controlling the supply chain. So the number of delivery points is being markedly increased, but the price is still being fixed. While India's manufacturing capacity permits larger scale manufacture for both the private market in India through open market supply, as well as for international export markets, as of yet, the government has not given permission to the Indian manufacturer to supply both in the open market in India as well as for the international market. On the other hand, India has begun to supply to other countries, and about 25 countries have so far been supplied vaccines under an international goodwill program, and also the COVAX program is also going to be receiving Indian vaccines. But given the fact that we are now going to be manufacturing many more vaccines in India, both those under development from Indian-developed vaccines, as well as internationally contracted vaccine. For example, even Novavax is going to be produced by the Serum Institute of India. The J&J vaccine is going to be produced by BioE, and therefore, and Sputnik is now being produced, the Russian vaccine, in India, and is awaiting regulatory approval. So we are likely to see a large influx of vaccines manufactured in India being available in India for rollout, and therefore the price control which the government will exert will still continue for quite some time till the priorities are met. And the priorities are defined both on the basis of initially on essentiality of functions being performed by people, healthcare workers, as well as other essential workers, and then by way of vulnerability, that is initially 60 plus people are being given without any need for showing evidence of comorbidities, but also extended to 45 plus age group with some evidence of comorbidities if they're under 60 years of age. But over a period of time, these age groups would be expanded to include lower and lower groups as the vaccine supply becomes available in larger quantities in India. And of course, one of the limiting factors is the availability of the health workforce, but even that is being expanded substantially, not only by the enrollment of the private sector, but also of training of many more vaccinators in primary health care. So the ability to fit in this into the broader framework of a still evolving universal health coverage program is very much there. And virtually the commitment of both the central and state governments to provide vaccine free of cost in government facilities still stands. But some of the state governments have said that every individual who wishes to have the vaccine will possibly be subsidized to get a free vaccine. And even some of the state governments are now extending it to other age groups also because of increasing number of cases coming in some of the states. So they're even looking at relaxing the age criterion even earlier than scheduled by the central government. So we are really seeing the vaccination program now increasingly being utilized as a public funded facility, which is strongly subsidized by the funding from tax revenues. But over a period of time, once the essentiality criteria and the vulnerability criteria are substantially met, we may see some entry into the open market. But the universal health coverage commitment of providing this as a public good still remains the principal anchor of the program in India. We are also seeing that the Indian manufacturing capacity is being sought for global supply chain. For example, the Serum Institute of India can produce more than 70 million doses per month. And recently there has been an investment promise of about $200 million from other countries, including the United States and Japan, for India to produce 1 billion doses for global supply. And even the International Development Financing Corporation is supporting BioE for production of vaccines, especially the J&J vaccine. So we are seeing global investment also coming in to support India's vaccine production, part of which will come into India's own utilization chain using the UHC framework, but part of it will go into the global supply chain and some of it to COVAX also, with principal emphasis on global health equity. Thank you.
Brilliant. Thank you so much, Srinath. It's wonderful to hear both India's approach within its UHC framework, but also India on the global stage. You know, a colleague of ours, Sanjoy Bhattacharya at the University of York, very early on, maybe halfway through last year, said, keep an eye on India, keep an eye on China, keep an eye on Russia. You know, in terms of the global supply of vaccines, they're going to be important players. And I think he was absolutely right. Ben, are you with us? I know we've tried to text, call or raise you. Ben Akabwezi, are you there? Let's move on to Fatima Hassan. She is the founder and head of the Health Justice Initiative. And what I'm really excited to hear about is The issue of pricing, IP claims in a pandemic, I think Fatima and I were just chatting earlier. There seems to be a dominant narrative that has taken hold, a sort of received wisdom in global health, that things like IP and patents and prices aren't the issue. I personally do not believe that. And I think I wish this narrative hadn't taken hold. I think there's a lot more we could be doing. And with that, over to you, Fatima.
Thanks, Gavin, and everybody else. So in my 5 minutes, I just want to make a few points that I think IP has everything to do with the situation of inequitable access in the global south, particularly in relation to COVID-19 vaccines. So you can have all the money in the world, you can have all the budgets that you want, but there's a supply crisis, and you can't address the supply crisis unless you deal quite firmly with intellectual property protections in order to scale up supplies through the sharing of vaccine know-how and through the sharing of vaccine knowledge. And if you don't do that, if you don't urgently ramp up manufacturing, which is also what the WHO DG has said, what Tony Fauci has said, what the Vatican has said, what many world leaders have said, you're going to have a serious crisis of achieving global immunity in the next year or two. So we're 1 year into this pandemic, of the declaration of a pandemic. We're still not treating COVID-19 technologies, including vaccines, as a public good. There's an unbelievable, quite strange emphasis in the middle of a global pandemic that is considered to be unprecedented in over 100 years. The emphasis is on intellectual property protections and on patent protections and on treating vaccines as a commodity instead of as a public good, which basically means that right now, currently in the world, there isn't wide sharing of vaccine know-how, leading to a supply crisis, which in turn has led to an equity crisis. So unless we ramp up manufacturing urgently, we are also going to be dealing with a moral crisis of how we deal with intellectual property monopolies during a pandemic. And remember that a lot of these front-runner vaccine candidates were actually co-developed with public support, public institutions, and government scientists. So in many cases, the public co-owns these vaccines, not multinational corporations. So that's how we get to the inequity problem. And we have, inequity playing out in several ways. The first is across nations, with a number of bilateral preferred access supplies and non-transparent pricing deals. The second is across suppliers, where they are honoring bilateral agreements for certain markets first, including for populations where there are young and healthy people, as opposed to healthcare workers, for example, in Africa or in the global south, where 130 countries are still waiting for sufficient supplies to even reach 10% of their population with vaccination. The third inequity is across institutions. We're seeing different companies agreeing to come into COVAX, different companies agreeing to supply the African Union Vaccine Acquisition Task Team. COVAX is only estimated to basically cover about 27% of vulnerable populations in low-income countries by the end of 2021. And so that's not just a shameful statistics, it also means that the project for global immunity is at severe risk. COVAX also relies on self-financing, on voluntary participation of companies. So the way in which these institutions that are meant to be providing equitable access to particularly low and middle income countries is something that needs to be addressed. The next inequity is in relation to the exportability of some countries and some nations. We're already seeing export bans. We're now seeing restrictions on sources, source supplies for vaccines also being prohibited from imports and exports in different contexts. And we're seeing now the first signs of vaccine trade wars between the EU, with the UK, with the US, and last week we saw the Italy and Australia example as well. And then we're seeing inequity across licensing. The sub-licensees, you've talked about Serum Institute, Merck, Sanofi, Novartis. I mean, aside from the fact that these agreements are not transparent, in most cases they are not public, the pricing inequities residing within those licenses are also an issue. And of course, we're now seeing that playing out across political ideologies. So the ability of Sputnik and potentially Sinopharm and Sinovac to be the main supplier for many countries in the low and middle income parts of the world, particularly in the global south, is something that obviously needs to be flagged. In South Africa, for example, Sinovac and Sinopharm, as well as Sputnik, have now submitted their dossiers for regulatory approval. So that will obviously influence vaccine selection over time in many parts parts of the global south. And then we're also seeing a major inequity across nationality, where countries who have populations under their occupation or countries who have large numbers of refugees and asylum seekers are not including them in the prioritization groups for vaccination rollouts. So what are the facts on the ground? We've got multiple variants, including variants being discovered in South Africa. We have an evolving virus. Immunity is now at risk globally. In South Africa, for example, which is considered a middle-income country for COVAX purposes, less than 100,000 healthcare workers have been vaccinated. It's March 2021. This is scandalous. Most healthcare workers in Africa are still waiting for vaccines to be actually administered. So yes, some supplies may be coming in, but the administration hasn't taken effect as yet. I mean, the WHO itself has indicated that in 130 countries, there's either been 0 vaccines administered or very few vaccines administered, with most of the current vaccine supplies going to about 10 wealthier countries. So what we're now seeing, Gavin, is actually a pernicious form of queue jumping. And we're seeing that queue jumping across nations. And then we're also seeing that pernicious form of vaccine nationalism within countries, where the rich are basically jumping to the front of the queue, or those with medical insurance are jumping to the front of the queue with scarce, limited supplies. And so the allocation is not actually being done based on epidemiological need or based on public health principles. So we get to the last point of who has the power in this pandemic, who's in the driving seat in this pandemic. It's certainly not governments, it's certainly not COVAX, it's certainly not the WHO. It's actually the usual suspects that we saw during the height of the HIV/AIDS crisis. And in my view, it's multinational companies. A few drug companies, about 7 or 8 of them, have basically got the world, holding the world to ransom and holding the world to a hostage situation. In the middle of a pandemic, they're still insisting on voluntary measures, where intellectual property and knowledge hoarding is basically the order of the day. And I think that's something that really needs to be addressed. So what we now have as a result of that hoarding of the vaccine know-how and the vaccine knowledge is we have limited, uneven sharing of intellectual property, still on a voluntary basis. None of those companies have entered the WHO CTAP. There's still a handful only of secret licenses, not even more than 25 licensees that we've been able to count. And in the last week, that number may have increased, but it's certainly less than 30. And there's obviously market segmentation and price segmentation. There are some companies that are refusing to enter middle income and low income countries. There are some companies that are refusing to even supply. And even though they're refusing to enter a country like South Africa, take the NIH Moderna vaccine, for example, they're refusing to sub-license another company that could manufacture that vaccine for South Africa or for countries that they don't necessarily want to enter. So the issue is, why are shareholders and CEOs determining in the middle of a pandemic who gets access, which markets they go into, who gets supplies, and how that prioritization should happen? Something is fundamentally wrong with the global order and with the system. And what we've seen, just to wrap up, is that in addition to blocking the TRIPS waiver, and in addition to blocking the ability of the third of countries in the global south to be able to use measures that would ramp up manufacturing in the global south, it's only when there's a political crisis in the EU or in the US that licenses are now emerging. And that is what we saw with the EU supply crisis a few weeks ago. And it's certainly what we saw in relation to the Merck announcement around the Johnson & Johnson manufacturing in relation to the US. So I'll end there. Thank you.
Brilliant. Thank you so much. I see that we have Ben, so we're going to pass straight to him. Let me just say 2 things. There is that map showing who blocked the patent waiver proposal and who was in support of it is really striking. You can see all the rich countries with their pharma industries. That's got to change. I've always had a hunch that the companies have thought, well, this is going to be an annual vaccine, right? That you're going to need a booster every year. And so, the profits ahead could potentially be large. And I think there is some evidence for that now. We have 4 minutes left. We had trouble connecting with Ben Akabweze, the Director General of the Budget Office in the federal government of Nigeria. But Ben, I think you are there. I spotted you briefly. We only have 4 minutes, but could you share, if you are there, your thoughts, maybe in 3 minutes, on Nigeria's approach to vaccine financing, if you are there? I glimpsed you briefly, or was it a mirage? If we are still having trouble, I'm going to take a few questions. Let's see. I know that Hannah Kettler was trying to respond to Shreth Mawandia by text. On COVAX, yes, the idea is this 2 billion doses that you've heard about, that COVAX is on course to deliver by the end of the year. That is not a random number. That is the number that would reach health workers and high-risk people first. That is the idea. And then as supply ramps up, then you go beyond the 15 to 20% of people. There's a very good question for the panelists about if you think outside of COVAX, are there examples of cost-sharing models involving the host government, the companies, WHO, private sector? Hannah, that's a very interesting question. Are there past examples from pandemics or even in this? Are there thoughts of any sort of cost-sharing approaches?
No, I think it's a great question. I was thinking and I was kind of drafting, but I mean, the India story that we heard today has some components of it, right? I mean, it's pointing towards and has the benefit of having a large local manufacturing capacity in order to have a sort of strategic discussion between the government and industry, as well as sort of the public health community. The African Union is having a separate conversation that's at the moment primarily focused on alternative mechanisms for procurement. I know that COVAX itself is thinking through sort of beyond the initial 20% or the doses that might be covered via the AMC fund. What might a cost sharing initiative look like? But I think there's lots of room, and what Fatima just described in her remarks, there's lots of room for additional innovative ideas for how do we move beyond what I think is a really essential start to getting vaccines out, but will not be sufficient to meet the long term. But I appreciate the question. Unfortunately,
thank you very much. Yeah. We only have 1 minute left. And there are a couple of questions. I'm really going to just pick one that, in order that they came, for Fatima, which is what can folks do? Is there a way to put pressure on the rich countries who are protecting IP and patents? I mean, there are activist campaigns. I've seen them. I've signed them. I mean, I think we should be sharing a lot. We should be sharing doses. We should be sharing know-how. We should be sharing IP. We should be sharing patents. What do you think? I mean, you've got a ton of experience in this world. What's the approach?
So there's two immediate things that needs to happen, particularly in the US. The Biden administration has to be urged, and they need to scale up the use of the US Defense Act beyond domestic protection and borders. So the provisions of the Defense Act have to be invoked for benefit of the rest of the world, basically outside of the US. So the hoarding, the not sharing of knowledge, that's important, but the Biden administration, particularly on the J&J and the NIH Moderna vaccines, the one that they've co-funded and co-developed with the NIH funding, they need to march in and basically take over that technology and assert their intellectual property protections and rights as well, because the US public actually co-owns those vaccines. The second is that the countries that are currently vaccinating, a number of their population, including the health workers, in some cases 33% in the UK, in some cases 12% in other parts of the world, are blocking the TRIPS waiver. Those 10 countries, you need to write to those governments to urge them to stop blocking the TRIPS waiver. So they're vaccinating their people, they've got bilateral deals, they're drawing from COVAX supplies like Canada, Australia, for example, but they're blocking the TRIPS waiver. So there's a certain irony in trying to protect your own, but you actually don't really care about the rest of the world. And that doesn't work when you have a mutating virus with a number of variants.
Thank you very much. That is an excellent place to stop. Ben, I'm sorry, I see a text from you. The daylight savings thing merely messed me up as well. So that just remains for me to thank the panelists, Mohammed Mustafa, Kan Zhang, Hannah Kettler, Susan Sparks, Ben Akabweze, who was with us in spirit. Sorry we didn't get to hear from you. Srinath Reddy and Fatima Hassan, thank you all so much for joining. We will make this video available. And Ben, what we might do is if you happen to have some written comments that we can share, we will post them on our website because it would be lovely to hear from you. Oh, there you are. There you are. I'm so sorry about the timing, Ben. But we would love to perhaps capture some of your written comments, or maybe you can even make us a 3-minute video that we can add to this one. So goodbye, everybody. Thank you so much for joining. And stay tuned for our next one. These are monthly. I don't know when, and I don't know the day or the time. I should have had that information at my fingertips if I had been a good moderator. Sorry about that, but I'm sure you can find it on our website. Thanks, everybody. Bye. Oh, April the 20th. There you go. April the 20th. Bye, all.